everybody. Today I like to present the how I treat complex fem-pop lesion. Today I speak for about the special character of the SMA is an proximal popliteal artery is this very challenging and complex lesion. It had a high stress and extreme force. Uh, 60 to 70% of all occlusive disease is occur in fem population, and it has the high incidence of the diffuse occlusive and calcified lesion. This is the our uh, algorithm of the SMA and fem population. We divide to the lesion. This is the simple lesion. We find is a heavy calcified. If there is no calcification, we will perform the vessel preparation of the SMA, and we look for the balloon response. If it response is good, no acute lactic recoil, so we perform the leave nothing behind concept. So we do the POBA or DCB. Mostly out of our case, we perform the DCB. But if the balloon response is not good, it's like a suboptimal balloon angioplasty or dissection. We put the scaffold. We can put everything: superior, BMS, cover stent, or DES. But if the lesion is a complex lesion or has a very heavy calcified lesion, we will perform the vessel preparation. From this, we can do all of the vessel preparation technique, such as the balloon angioplasty. Mostly, we use the high pressure balloon and some special balloon and debulking and lithotripsy. And we look for the response. If the response of the vessel preparation is good, so we do the leave nothing behind concept. We do the DCB, and sorry. But if the response is not good, we use the stent. We can use the superior BMS cover set or DS. You can see if the lesion is complex lesion, heavy calcified lesion, mostly the response of the balloon after vessel preparation mostly use the scalp flow. So the superior stent is the vascular mimetic implant. It consists of 6 closed end interwoven retinal wire, and the delivery system is the unique thumb slide design, and we can use both of the O14 and O18 guide wire, and this is the over the wire delivery system. The unique of the SMA, the stent, the superior stent is the mimic of the natural structure and movement of the anatomy. It provides strength and flexible for more durable solution, and it had a lot of clinical of the stent in the SMA. The superior is not the same as the other stent, because when you sizing of the superior, this is the vessel, the inner vessel. It means when you sizing, it should be the same size as the outer of the stent. You be sizing one by one to so it needs the preparation of the vessel and to minimize chronic outward force. If we can perform deploy the superior in nominal deploy, we can achieve the 91% of patency in 1 year, and freedom from TLR at 3 years, 93%, 94%. Uh, the uh, the superior can have the high compression resistance and low chronic outward force and high flexibility and fracture resistance. This is the uh, the character of this supera. And the clinical outcome of the stent, we have a lot of the stent of a lot of clinical trial from the supera. First is a superb trial 1-year outcome of supera. We can use the supera in the subintimal stent in CLI and can achieve the 94% patency in CLI patient. Superb 3 years result show the supera has strong clinical outcome in case of severe calcification, and 5-year patency of the long and calcified lesion is 64%. When we compare supera versus the drug coating balloon and bare metal stent, we can found that the supera demonstrate durable long-term outcome compared with the DCB and BMS. In the long lesion, up to 24 centimeters length, and high-risk patient, mostly of the patient has 78% of tax C and D. We have the 1-year patency 95%. Okay. From the 1-year primary patency of the SMA the stent, this is the portfolio of the stent. We can see that from the superb trial, the supera has the patency in 1 year around 91%. This is the most the highest primary patency in the study. Even though in the very long lesion of the SMA, in the SMA, the longest lesion in the study is 24 centimeters. They also have the 91% patency in 1 year. And how to selection the strategy, because we have the very complex lesion like a calcification, dissection, or acute elastic recoil. The calcium, as we know that it is the very the risk factor of the suboptimal patency. So we can, I think that you already know that the classification, we have the PAC classification from the IWAS classification, or we have the OCT as well. You can see when we put the stent, I mean the bare metal stent, we can see when we use the IWAS or the OCT, the stent is collapsed. It's become the D shape when you put the stent in the very calcification lesion. But when you put the supera in, the vessel is circular geometry. So the supera has the high compression resistance in the heavy calcification. About the dissection, we also have Fujihara classification of dissection. We know that the class C, D, E, F is the indication for the stent. So we, like here in the picture C, you should put a stent, the spiral dissection, or the very filling defect or slow flow of the contrast. We see that the task, the section class C, D, E, F has the significance of the restenosis. So we should put the stent in this kind of the dissection. The supera is the profile of the low chronic outward force. And for the acute elastic recoil, we found that when we do the procedure, when we balloon the lesion, we have the acute gain of the vessel diameter, and after that, when the patient has the acute elastic recoil, so the vessel diameter is reduced, and the supera has the low chronic outward force and high compression resistance, and this may be the description for the primary patency 1 year of supera is 91%. This is the complex case of the heavy calcification. You can see the superior can put in the heavy calcification and with the sakura of the lumen. And for the subgroup of the heavy calcification in superb study, we found that the patency in 1 year is 89% and freedom from TLR is 88% in 3 years. For the complex lesion, in TARC, CD, and CTO lesion, most of the patency is up to more than 80%. This is a superb 3-year result. They do the subgroup analysis for the severe calcification. We found that 89% 1-year patency, 88% freedom from TLR at 3 years, 0 stent fracture in 1 year, and primary patency. If we can deploy nominal deployment is 90%. And the freedom from TLR, if we can deploy the nominal deploy, we have the patency freedom from TLR 94%. As we told you, that if we can deploy nominal, we can achieve the freedom from TLR more than compress or elongate the deployment. So we need to know how to deploy superior perfect. First, we have 3 steps of superior deployment. First is vessel preparation. You need to deploy the pre-dilatation of the vessel more than the outer of the more than or equal to the outer diameter of the stent. And we recommend to do the longer infiltration time. Like when we want to deploy the 5.5 mm of the superior, it means the outer diameter. So you need to prep the vessel 5.5 or 6 mm. And we need to match size 1 by 1 of the vessel diameter. Do not oversize the implant and cover all the lesion and vessel preparation. And deploy, when we deploy, we need to magnify the image to see the cell geometry. And this is the distal sheet marker. This is the stent length of the markers.
Did you have so many experience about superior stent? You deploy so many, right? Okay. And you guys not so many, no? Okay. ฮะเขาพูดไปเถอะไม่เป็นไรหรอก Okay. Because superior, this is like a step deployment. It's not very precise. It's not like pullback, and it's not like thumb wheel. It's like a step by step, and also the length of it is not very accurate. But you have to prepare, and you have to prepare the blood vessel first. It needs the bigger lumen than the stent. So after this, we will demonstrate in the case. Okay.
This is the system of the superior delivery system. The thumb slide. This is the system lock, and this is the deployment lock. This is the video of the superior. เสียงอ่ะพี่เสียงมี
System lock. Deployment lock. Outer sheath. Stent driver. Catheter tip. Stent. Note that the superior implant is constrained at approximately 3 times its nominal length within the delivery catheter. Proper deployment is critical to restoring the superior implant to its nominal state. maximizing its radial strength and flexibility. The distance between the distal sheath marker and the stent length marker indicates the nominal length of the implant. The markers have significance only prior to implant deployment, serving to identify the distal and proximal landing zones. The labeled diameter of the supera implant is based on the outer diameter of the implant. Inflating a PTA balloon prior to the supera implant deployment will prepare the vessel to accept the implant's outer diameter. The stent diameter and vessel preparation table displays the recommended minimum balloon inflation diameter for each corresponding labeled stent diameter. Select a stent diameter corresponding to the reference vessel diameter in a length long enough to cover the target lesion. For this example, a 5.5 millimeter supera has been selected. Prepare the vessel utilizing standard angioplasty technique using a balloon size greater than or equal to the stent diameter. Prior to use, supera should be removed from its packaging, inspected for bends or kinks, flushed and wiped prior to use per the instructions for use. The supera catheter should be introduced into the sheath utilizing a 0.014-inch or 0.018-inch guide wire. Advance the system until the distal sheath marker and the stent length marker encompass the target lesion. To initiate deployment, rotate the system lock to the unlocked position. Do not unlock the deployment lock. Slowly advance the thumb slide. Increase magnification to better visualize stent deployment. Maintain increased magnification during the entire stent deployment procedure. Continue controlled advancement of the thumb slide under fluoroscopy. Each full advancement of the thumb slide will only deploy a short section of the stent. Shorter thumb slide advancements may provide greater control versus full thumb slide advancements. Fluoroscopic visualization and tactile feel will indicate the end of stent deployment. To release the supera implant, rotate the deployment log to the unlocked position. Slowly advance the thumb slide to complete deployment. Following confirmed implantation of the supera stent, retract the thumb slide in a single motion to the starting position on the handle and rotate the system lock and deployment lock into the locked position in line with the thumb slide. Under fluoroscopy, remove the device from the guide wire and evaluate the improved luminal quality of the treated area. The supera implant is an effective option for the dynamic environment of the SFA and proximal popliteal. Its unique design mimics the natural anatomy for durable outcome.
Okay, and this is the you can see from the stent. This is the ideal or nominal deployment. We have the horizontal diamond here. Is 2 by 1, but this is not optimal. It's so compressed of the stent. It's like a horizontal diamond, and this is the suboptimal. It's a vertical diamond. So this is the good deployment. You can see
because this is the step-by-step deployment, and sometimes we have to pack. Sometimes we have to elongate the stent a little bit because it's up to the vessel preparation. Sometimes the vessel have severe calcification. The stent have tend to have elongation at the point of calcification. So we have to pack a bit. So this is the very good packing. The first one, very good packing. If you pack like this, the patency is very well. The best patency is the best. But if you follow by the second one, if you have too much packing, maybe the patency is not the best, but it's also very well. But for elongation, the patency reduced so much. Maybe the first one maybe 90, about 90 in 1 year, but for suboptimal is about 70, about this.
เคสอันนี้เคสไม่ต้องแล้วค่ะภาพเลยนะคะเดี๋ยวไปดูเคสจริง This is the case.
This is
The demonstration. 47 years old Thai males, heavy smoking, and for the right side they have the ganglion of the foot, and the pulse of the femoral is full pulse. The rest is cannot palpate. This is the angiogram. Sorry. This is the angiogram of the lesion. This is the common femoral artery, SFA, and distal SFA is occluded, and you can see the heavy a big of the collateral in the SFA, and the rest is good. BTK is no disease. PTA, peroneal. This is the angiogram of the foot. Posterior artery. So we do the anti-6 French teeth retrograde contralateral puncture. Here we can we do a lot of time to do the recanalization, but otherwise we always go to the big collateral. So we do the antegrade puncture of the popliteal artery P2 and can do the recanalization. After that, we do the pedalization here, and I think the vessel is around 5.5, so we with the 6 mm balloon. Now it's look okay. So we put, after that we put the stent.
Actually, for this case, it's a bit difficult if you come from above, because there is the big collateral, and there is like a flush occlusion. You may demonstrate a little bit. Is if you try to come from above.
ไปถึงไหนแล้วเดี๋ยวก่อนโทษนะคะทำนี้อันนี้
It may go down to the collateral. So you can try from above for a while, but I think in my opinion it's difficult, because if you try to do recanalization of the total occlusion, this isn't the occlusion point. This is the real occlusion over there. This is a big collateral. So if you try to insert the wires go down to the collateral. So I think to come from above is difficult. So in this case, I think maybe come from below too.
Yes.
Come from below.
Yeah, we come from below. Let's look at puncture for detail.
Oh, actually, first, we do contralateral groin puncture. Contralateral, but come from above first, and if the case is difficult, we come from retrograde approach. Actually, if it's up to the popliteal artery, if the popliteal artery open, and there isn't any disease of there isn't any severe disease of BTK that we want to recanalize, just only puncture of popliteal artery and do retrograde puncture and retrograde upward from below. No. actually from like a supine position, but a little bit flock leg. Yeah, a bit. We if you can, we can do just we can do puncture over P1 segment. P1 segment it we can, because ultrasound is a little bit too deep inside the leg. So if you want to puncture the P1 segment, you can do by angio by the flow guide, horoscopic guiding puncture. Sometimes you need roadmap a bit for guiding you to do puncture. But if you want to puncture at P2, ultrasound guide should be better, because it's just superficial a bit, and you can do ultrasound like it's a little bit tricky, but no problem. And if you want to do puncture at the P3, you can do fluid guide again. You may move the leg, maybe abduct a little bit. I'm sorry, internal rotation. Have internal rotate a little bit, and you puncture between tibia and fibula space over here, and do puncture at the P3. If we have a difficult case of SFA, maybe we will demonstrate the puncture, the retrograde puncture for you. Okay.
Okay, it's time to conclude. Yes, the superior stent is a high compression resistant, low cooling out force, and high flexibility and fracture resistant. This come to the high patency rate of the superior. So you need to selection, preparation, and deployment the technique of the superior stent. Thank you. The next is case presentation.
Do you have any question about superior stent? Or you can discuss about SFA lesion in general, no problem. Actually, Dr. Nutsiri also the expert in SFA, BTK, anything. you can ask her.ยังไม่ได้